Assalamu alaikum. Good afternoon, everyone. Topic of my presentation is cervical cancer screening and vaccination, with particular focus on Bangladesh perspective. Firstly, a bird's eye view on global situation. Cervical cancer is a declared public health problem globally, and comprehensive analysis of any problem hopefully usually lead to a solution. This colorful picture showing differences in cervical cancer incidence rate worldwide. Red areas are incidence of with high incidence, and dark blue areas are areas with very low incidence. And this picture is a representation of discriminatory attitude of cervical cancer in low resource settings. According to the latest Globocan data, cervical cancer ranks fourth among female cancer. And in Bangladesh, it is the second leading cancer after breast cancer. Cervical cancer is almost 100% preventable. Since 1950, death rate of cervical cancer has decreased by as much as 70%, but mostly in high-resource settings. Yet, in 25 countries, cervical cancer is the most frequent cancer, and in 37 countries, it is the most leading cause of cancer death. 90% of cancer cases and death occur in low and middle-income countries. Currently, one life is lost every 2 minutes due to cervical cancer. Due to wide range of discriminatory inequality in frequency and death, WHO launched the global strategy to accelerate the elimination of cervical cancer. To define elimination, 4 or less than 4 cases of women per lakh women is set as threshold, and we are hope that elimination should happen within the lifetime of today's young girls. The 90-70-90 target set by WHO, that is 90% target girls will be vaccinated, 70% target women will be screened, and 90% cervical precancer and cancers should be treated. To accelerate the elimination, WHO updated the guidelines, first phase update in 2021, and very recently in 2024, the second phase update is published. WHO strongly recommends HPV DNA test as primary screening test rather than VIA or cytology. Until HPV DNA test is operational, existing program with cytology should be continued, but existing program with VIA should be transitioned rapidly. These are important points in WHO guideline. Age 30 to 49 is prioritized for target group for screening, but age 50 to 65 is also prioritized when resources are available and if they are not screened previously. Another important point is that neither VIA or ablative treatment are suitable for screening of menopausal lady as inadequate visualization of transformation zone. The screening interval for HPV DNA test is 5 to 10 years, but screening interval for cytology or VIA is every 3 years. In the latest updated guideline of WHO, what is new? Here, HPV messenger RNA testing is recommended as primary screening test. Dual stain cytology is suggested as triage test in HPV DNA positive cases. But this should be implemented within a health system with adequate laboratory infrastructure, quality assurance, and provision of management and monitoring. Now, success story of Australia. Australia is on track to be the first country to achieve cervical cancer elimination. Here, in 2007, a national HPV vaccination program started as world's first country. In 2013, they introduced male vaccination, and in 2018, nonavalent vaccine was introduced. This figure shows the decreasing trend of cervical cancer incidence in Australia, and by this trend, by 2035, Australia will achieve elimination of cervical cancer. European region, in collaboration with WHO, already published roadmap to accelerate elimination. Europe's Beating Cancer Plan calls for vaccination of 90% target girl and also screening of 90%, not 70%, 90% target women by HPV DNA test. Obstetrical and Gynecological Society from India, FOGSI, has their own recommendation based on resource availability. For good resource setting, screening by HPV DNA test is preferred, but with low resource setting, screening recommendation is VIA, but HPV DNA test can be done when it is affordable. Very recently, on 10th December this year, United States Preventive Service Task Force has published their latest recommendation. Here, 21 to 25 years age, pap smear is the screening test, but in 30 to 65 years of age, HPV DNA test is a preferred screening test, both sampling and provider-collected sample. Now, Bangladesh situation. According to Human Papilloma Virus and Related Cancer Fact Sheet 2023, age standardized incidence rate of cervical cancer in Bangladesh is 10.6 and mortality rate 6.67 per lakh women. In our country, we have official national recommendation which has started in 2018, but active invitation to screening is not yet possible. This is our national strategy for cervical cancer prevention and control. The key strategic direction for this cervical cancer screening includes target population 30 to 60 years of women, frequency of screening every 5-year interval, screening test is VIA, and in all VIA positive cases, colposcopy should be done, and colposcopically high-grade lesions should be treated following see and treat strategy. For population-based cancer screening, health information system is necessary, and in Bangladesh, district health information system is established since 2010 in all levels of healthcare infrastructure. VIA and CBE facilities has used this information system to collect data, and now it is customized and upgraded for data collection of each individual woman since 2018. Electronic data tracking with population-based cervical and breast cancer screening program is our current program, which includes dedicated server, unique registration number of each woman using NID, and here demographic data, result from primary screening, colposcopy, follow-up, all are included. This is the registration form for electronic data tracking and population-based screening. So at a glance, from registration to referral, awareness creation is done at by home visit or Uthan Boitok, and at community clinic, e-registration is done. At Upazila Health Complex, there is also facility of e-registration. Here, VIA is done, and in some Upazila, there is provision for screen and treat. All screen positive patients are referred to Medical College Hospital, District Hospital, and National Institute for further management, where colposcopy and treatment of cervical disease done. This is a research report, electronic aggregated data collection on cervical cancer screening in Bangladesh. It summarized that a national cervical cancer screening program using VIA method and DHIS2 based electronic data collection backbone is effective, sustainable, and useful to understand screening coverage, VIA positivity rate, and geographic distribution of participants. This is our cervical cancer coverage percentage. It is up to mid-year 2023. The coverage is 15.54%. I think our expert panelist, Professor Ashrafun-Nessa, will show or tell you the current coverage rate. Okay. Now some points on HPV vaccination. The first vaccine for prevention of HPV-related disease was licensed in 2006. And after several large-scale RCT, it is evidenced that a single dose HPV vaccine is sufficient to elicit immune response as much as like as multi-dose regimen. Systematic review have shown seropositivity among subjects who receive one dose to be non-inferior to those who receive 2 or more doses. So WHO strategic advisory group of experts recommends single dose vaccination, 1 or 2 dose for girl age 9 to 14 years, 1 or 2 dose for women age 15 to 20 years, and 2 dose for women more than 21 years. In Bangladesh, HPV vaccine was first introduced by pilot study, which was pioneered by Professor A.K. Goodman and Professor A.B.M. F. Korim, who is the founder of this oncology club. And a committee was formed for this study, and our chairperson, Professor Sabera Khatun, was the leading person in this piloting. Thereafter, HPV demonstration program was done in Gazipur in 2016. After first year, the coverage was 87%, and after second year, the coverage was 99%. Recently, our government has launched nationwide human papillomavirus vaccination campaign. Last year, in October 2023, in Dhaka division, it was happened, and here we could vaccinate more than 15 lakh target girls, who are 75% of our target population. And very recently, in October this year, the second phase launched and finished. And despite of challenges related to rumors and vaccine hesitancy, timely actions to rebuild trust enabled us to achieve an impressive 93% coverage. These are some pictures formed for creating awareness of HPV vaccination. Thank you, everyone.
Thank you, Dr. Rifat Ara. Now, I request Professor Shahana Madam to conduct the session.
Assalamu alaikum and good afternoon. Dignitaries in the dais, respected chairpersons, distinguished guests from home and abroad. Now, as all we know, and Dr. Rifat Ara, he described all the things about the cervical cancer screening and HPV vaccination in international perspective and Bangladesh perspective. Now I requesting our panelists to answer in short, as because we are running in short of time about this, the question answer sessions. At first, single dose of HPV vaccination, a game changer for cervical cancer prevention. Is it really justified for Bangladesh perspective? Dr. Professor Farhatana Madam, what is your opinion?
Hello? Hi, it's working. Single dose vaccination for cervical cancer uh, is really justified in Bangladesh perspective. The concept behind is that we know that single dose vaccination reduces the vaccination cost and delivery, and at the same time, it simplifies the implementation. So more and more girls can be vaccinated instead of vaccinating a few girls with 2 doses. Thus, being a low resource country, HPV vaccination by single dose will increase the coverage of patients. So in my opinion, it is justified.
Thank you very much, madam. Thank you for your nice and justified answer. The data from immunogenicity trial, a single dose of HPV vaccine is sufficient to elicit an immune response that provides similar protection as multi-dose. And there is already Dr. Rifat, he is informed that RCT, there is RCT in 2,250 patients were sexually active 15 to 20 years old females were randomized to receive either bivalent or the nonavalent vaccine group. And they recommended that if we give the single dose vaccine, then we can cover the more population. And there is a study, as this report is writing up to the December 2024, the 37 countries around the world have reported switching to the single dose regime. So we are going forward for the single dose vaccine. My next question is, what are the reasons for slow uptake and low coverage of the HPV vaccine? Professor Dr. Jannatul Firdaus, in our target population.
Dr. Shahana Parveen. Yes, though HPV vaccine has a tremendous impact in reducing cervical cancer and precancer, but it's true that the uptake is slow and the coverage is also low in the target population. The causes are actually there are 5 causes. Number 1 is lack of awareness, and there are certain misconceptions, like many people think that their belief is that the vaccine could promote sexual activity, fear of side effect, and it may be unnecessary. The second cause is there is access and delivery challenges due to cost barrier and due to ineffective delivery systems, and also due to limited healthcare infrastructure. There is limited access to get the vaccine. Number 3 is vaccine hesitancy and distrust due to some anti-vaccination movement and misinformation campaign that may erode the public trust in vaccine. And also, obviously, there are certain cultural and religious beliefs that may discourage to be vaccinated. Number 4 is policy and programmatic barrier, because lack of prioritization and weak health system may struggle to implement effective vaccination campaign and monitor coverage rate. And number 5 is gender inequality, especially for women and girls in marginalized communities. So these are the common barriers, and we need to address the barrier to overcome the situation. Thank you.
Okay, thank you. Yes, you have rightly said that even after that is higher life-saving vaccine, even the slow and coverage in countries much lower than the 90% targets. And in 2020, global coverage with 2 doses was only 13%. And the factors you have already stated, and all these are factors you have described, we have shown in the screen in all those. My third question is...
But I would need to add something, because in the first phase of campaign, in perspective of Bangladesh, the targeted was 2.3 million, but we could have achieved only 1.5 million phase. But in the second phase, that was out of Dhaka in the 7 divisions, the targeted population was 6.2 million, and we could have achieved 93% of the coverage. So Frankly speaking, the first phase coverage was not good enough, but when you compared the target population in the second phase, the coverage was
Yes, we are
quite
coming
good, quite
there, yeah.
good.
Whether the gender neutral HPV vaccination should be included in national immunization program of Bangladesh, Professor Dr. Rokean, what is your opinion, and what are the advantages and disadvantages of the male vaccination?
Actually, we are just a beginner of girls vaccination. We want gender neutral HPV vaccination in our country, definitely. But before that, we have to cover our girls. It is also advantageous to give vaccine in boys and boys along with girls, because we all know there is 6 diseases are prevented, 6 cancer are prevented by this way. And one other important issue is in international country, all other countries, that is the genital wart. Genital wart can be eliminated by this vaccine. This is one of the benign disorder, but very cumbersome and very painful condition. And other 5 cancer can be eliminated by this way. Whatever the literature and other recited that there is disadvantage. Disadvantages of male vaccination is just same as girls vaccination. This is just few. This is simple, like all other vaccination. Pain in the side, hypersensitivity in some cases, and swelling and some feverish. These are the minor ailments, but not the major ailments. So I think that if in future we could provide nationwide neutral HPV vaccination, that would be better for us. Along with this, I want to say that as Bangladesh is a low resource country, but we are very proud that we have a very good infrastructure of healthcare system. Along with EPI, we could also implement girls vaccination, and then in future, if our government permit
Okay.
it, we can
The-
promote
yes,
neutral
madam.
HPV vaccine.
Yes.
Important thing is that cervical cancer is a public health problem. But on the other hand, when you consider the male partner, the cancers that happens in male are not the public health problem. So priority must be given because of the low resource setting to the public health problem. And that's why now the current situation is not the time to start the male vaccination.
Yes, madam. Yeah, we are running short of time. Yes, there is the both.
That vaccinating the males, we can produce herd immunity. By vaccinating both male and female,
Yes, yes.
the number of infections, prevalence of infections will be less, and so that the woman can, the partner, when the partner is safe, then the prevalence of infection and
But it is-
subsequently
yes,
cervical cancer.
yes,
will be
in
less.
countries with HPV vaccination coverage of 80% or higher among girls, boys are already well protected by the herd immunity. So, which renders the gender neutral the vaccination, this is less cost effective. But intervention to increase the vaccination coverage among the girls where it is low might be the more cost effective than adding vaccination of the boys, because if we cover all the girls, then the boys will get the herd immunity, and it is best with the high levels of the immunization against the girls aged 9 to 14 years. My fourth question is the pioneer of this vaccination program, not only vaccination, he is the screening program. She is the lady, Professor Dr. Ashapunnesa Madam. She is the project director of the screening program and cervical cancer and breast cancer, and in the Bangabandhu Sheikh Mujib Medical University. If a lady from a higher socioeconomic condition in Bangladesh come to her OBGYN specialist for vaccination of her daughter from private setting, standard dose or reduced dose, single dose, which one should be advised? And how this information of vaccination at private setting will be included in the in our data system, because as you have already completed the data set, you have entered into the data tracking system, and if they get the private setting, how can we include this? Otherwise, there will be the low tracking. Your opinion, please, madam.
Thank you. For private setting also, we should advise for the single dose, but obviously, as the cost does not matter, they can take also double dose. And regarding the vaccination in the private setting, actually we have to increase the awareness within the society, because the government has introduced the vaccination among the 9 to 14 years girl through the school-based setting. So in the school, all the girls are getting vaccine. But if you want to catch the private setup, we have to increase the awareness, the OBGYN and others people who, who are working with the adolescent girls particularly, and other related things. They need to increase the awareness about purchasing the vaccine, because 2 or 3 vaccine brands are also available at the private level, and also the practitioners can advise more and more. So that will also help to increase the coverage in the private setting. Thank you.
Okay, madam, thank you. As we have already, there is the universal program in 2 rooms, so we have to short the. I am going to the, which is very important, that is screening. Now I am the switch over to the screening, the questions of the screening. That to eliminate the cervical cancer, a country should update the screening guideline based on local need, culture, and the available resources. What important points should be focused on our upcoming guideline? Professor Farhatara, madam, please. Please
the guideline,
be short, because we are only the 3 minutes.
I'm telling in very short. According to Bangladesh perspective, we are starting the screening at the age of 30 years. But matching with the global scenario, we are behind, we are starting it late. So according to global scenario, this has to be changed, and many of our girls are married before the age of 20 years. So the screening schedule should come much earlier for Bangladeshi girls also.
Okay. I want to hear from Professor Salma Roof, madam. She is the Secretary General of OGSB. What will be your role as you are the policy making chair? I want to hear from you, madam, please.
Thank you. First of all, I would like to express my sincere thanks to the organizer for inviting me to chair the session. Actually, the theme is deep dive in cervical cancer elimination, and actually this is a very time demanding. We need to take a deep dive, because we know that cervical cancer is one of the preventable cancer death in women, and there are some windows where we can start our action, but still it remains the second most important cause. Now, we are fortunate enough that our government has already taken the initiative to vaccinate, and along with the alignment of WHO, so we have started the program of vaccination of our girls. So that we have to encourage, that we have to support. And in this respect, our Obstetrical and Gynecological Society has already published a concept paper, the fact sheets, which are available in our website, and we give instruction to our 19 branches and all the secretary and president of those branches to create awareness among their members, to do the workshop, to go to the school, do the campaign, so that they can eliminate the misbelief, the superstition, and overcome the taboos. That was the reason for low coverage in the first trial in the Dhaka city. But we have successfully overcome this, and then the vaccination rate is improved in the subsequent subsequent division when we go to the phase 2. And that is why, and we are also working with WHO, UNICEF, to improve the situation. So hopefully, and I need to also mention that we need to keep alignment with the government program. So government is giving a single dose vaccination, so we have to stick to this, so that there should not be any chaos or any misconception or discrimination among the general population, so that they don't have the fear to have only single dose, or may be confused to have a double dose or like that. So first of all, we need to have a wide coverage. We should attain the 90% coverage, and then we think about how to give importance to male vaccination or like other things. So I think this is a great step, and if we go through this, we can overcome the situation. We have a very
Yes,
good control.
madam.
Thank
Right
you.
message you have given, sitting in the chair and sitting on the policy for all of our doctors, and we are very happy hearing from you. What are the challenges to develop a population-based cancer registry for cervical cancer in Bangladesh? Professor Sabra Khatun, madam, as you are working about the cervical cancer also and you have done the different program in private sector in OGSB hospital along with the OGSB partner. Your opinion, madam, please.
It is a great challenge to develop a population-based cancer registry. If you say that population-based cervical cancer registry, then it will be easier. But to develop a population-based cancer registry, it is very difficult because it needs to incorporate the other persons of the cancer of the whole body. So population, if we want to do a population-based cervical cancer registry, that will be easier because cervical cancer, we are working for the cervical cancer for a long time, and screening for cervical cancer almost established, though it is by via, we can also establish screening by HPV DNA test. And from screening to management of cervical cancer, we can establish population-based cervical cancer screening registry. But to establish a population-based cancer registry, it is very difficult.
Okay, thank you, madam. we are in
Thank
a
you,
dilemma.
Professor Shahana, for giving me the chance.
I am so
to say
sorry
something.
because there is already another program, professor. Yeah, I apologize to you all, and we are very much happy. That's all the senior teachers. They are sitting from morning for this program, and I am grateful to all of you because we have too many questions, and their audience, they have so many questions to ask. So I think in future, if we get this opportunity to discuss in our Bangladesh Obstetric and Gynecological Society of Bangladesh, in that session, I think we can discuss on this. Thank you all. Thank you again for our and also the audience for patience hearing.